Hello, and welcome to this faculty development snapshot on evidence-based medicine, tools for integrating diagnostic reasoning at the bedside. My name is Shanu Gupta. I am an academic hospitalist at USF. Overutilization in medicine affects not only the patient as an individual, but also providers and institutions, and more broadly, our healthcare system. In fact, it has been suggested that overutilization is the most important contributor to high healthcare costs in the US. As educators, we hold the opportunity to encourage learners towards providing high-value, cost-conscious care through the consistent use of evidence-based medicine applied directly at the bedside. To start this conversation, I'm hoping to help you gain confidence in applying likelihood ratios to the bedside physical exam. We will also review accessible EBM tools to utilize in bedside learning opportunities. To start, here is a case to test yourself. A 62-year-old woman is evaluated for chest pain, dyspnea, and hemoptysis. The pain is not consistently associated with exertion, nor is it always relieved by rest. It sometimes occurs when she's eating or when she's anxious. She does have a 30-pack-year smoking history. She quit smoking 2 years ago. Medical history is significant for hypertension and hyperlipidemia, for which she takes lisinopril and rosuvastatin. She has been treated for breast cancer for the last 2 months. Physical examination shows tachycardia and unilateral leg swelling. An electrocardiogram reveals sinus tachycardia. The patient's pretest probability for acute pulmonary embolus is estimated to be 50%. CT angiography is performed. This test has a positive likelihood ratio of 10 and a negative likelihood ratio of 0.1. The patient's CTA is positive. Your student says to you, "This is obviously a PE. I'm going to start anticoagulation right away." Now you could say, "Sure, why not?" Or you could use this as a teachable moment and ask the student, "How sure are you?" Anticoagulation is a risky therapeutic strategy. We need to know if we're doing the right thing. So, which of the following best approximates the patient's post-test probability of acute PE, knowing that the CT angio was positive? We'll get back to the answer for this question towards the end. In decision analysis, there are generally two threshold probabilities involved: a testing threshold and a treatment threshold. We can assign values to these thresholds using data on the reliability and potential risks of the diagnostic test and the benefits and risks of a specific treatment. If a patient's likelihood of disease is lower than the testing threshold, we can forego testing and treatment. For example, a pregnancy test in a male patient. Similarly, if the probability of disease is higher than the treatment threshold, we would treat without further testing. Think of a patient that presents with SATs of 80%. You place oxygen on them well before you examine them to elucidate a cause. A test is only needed with treatment depending on the test outcome if the probability of disease is between these two thresholds. This is where likelihood ratios come into play. The likelihood ratio, or LR, is the likelihood that a given test result would be expected in a patient with a target disorder compared to the likelihood that that same result would be expected in a patient without the target disorder. By contrast, sensitivity and specificity are properties of a test. They represent how a test performs when you already know a disease is present or absent. I usually have to convert those to positive and negative predictive values before applying them to the patient in front of me, and recall that those change based on prevalence. The likelihood ratio, on the other hand, does not change with the prevalence of the disorder. For ease of clinical use, this table identifies some general LR rules. Positive LR values of 2, 5, and 10 correspond approximately to an increase in disease probability by 15, 30, and 45% respectively. Similarly, negative LR values of 0.5, 0.2, and 0.1 correspond to a decrease in disease probability by 15, 30, and 45% respectively. Larger positive LRs and smaller negative LRs are more apt to affect clinical decisions. Focusing on physical exam findings with LRs of 3 or more, and those of LRs of 0.3 or less, teachers have identified the most accurate physical signs, those that change disease probability 20 to 25% or more. The LR is used in conjunction with a pretest probability, most often the prevalence of a given disorder in the general public. This Fagan nomogram represents the effect of the LR on post-test probability. It is not a linear relationship. Let's put this into practice. Mr. J comes to you in your office and incidentally complains of dizziness. Your first question is he having a stroke? You recall your ACLS training and astutely perform the Cincinnati pre-hospital stroke scale and decide to get him directly to the hospital for In the emergency room, the first point of decision is made by evaluating for a focal neurological deficit that is persistent, started within the past week, without head trauma. If none of these findings is present, the LR is 0.14. If all 4 are present, the LR is 40. If we know that of all patients presenting similarly to an emergency room, 10% are having a stroke, then with 0 of the factors noted previously and an LR of 0.14, the post-test probability falls to about 1.5% and thus does not meet your testing threshold. Without additional convincing evidence, you could probably safely say this patient is not having a stroke. When faced with an unknown LR, as in the case of 1 to 3 factors being present, the test provides no utility and the post-test is considered at least the same as the pre-test probability, meaning there is not enough evidence to rule out the disease, but not yet enough to confirm, and thus a different test is required, such as an MRI. If all 4 factors are present, focal, persistent, neurological deficit that started within the past week without head injury, then with an LR of 40, your post-test probability is about 80%. This is beyond your testing threshold and beyond your therapeutic threshold. Since we know time is brain cells, with the right clinical scenario, you may even skip the confirmatory test and go straight to treatment. In this case, of course, we would ensure this is not a hemorrhagic stroke, the rare case where a test is performed to rule out a disease since therapy has significant consequences. Now, what happens when you don't have the prevalence? You may consider how closely the patient's symptomatology matches the illness script and consider using base rates of a disease in your context as a surrogate for pretest probability. Additional resources are provided in the references. Now back to our 62-year-old woman who is evaluated for chest pain, dyspnea, hemoptysis, who also has sinus tachycardia and unilateral leg swelling. Her pretest probability for acute PE was estimated to be 50%. A CT angio was performed. It had a positive likelihood ratio of 10, and indeed the patient's CTA is positive. Which of the following best approximates the patient's post-test probability of acute PE? Well, your student has been paying astute attention to your EBM lecture and using the 15-30-45 rule provides the correct answer, which of course in this case is 95%. Anticoagulation is indeed warranted without the need for further studies. So to conclude, we discussed today the role of testing and treatment thresholds on medical decision-making. We used likelihood ratios to interpret bedside exam and testing outcomes. And now it's your turn. What's one thing you've learned today that you will put into your teaching practice? And what is your commitment to your learners? Thank you for your attention. Here are some additional references for you to utilize in your teaching and learning practice.